Welcome each and everyone. So once again, very good evening, everyone. I'm Viraj, Product Marketing Manager in Mindray India. And on behalf of my entire Mindray team, I would like to welcome each one of you in the second season and second session of Gyaan Ultrasound series, which is done by our Dr. Aniruddha Kulkarni sir. So today's topic is on acute pelvic pain transvaginal evaluation. So once again, thank you everyone for being part of this series and being part of the last season as well as last session as well. So as I said, this is the second season and the second series, which is today on 6th of March, Thursday, which is said to be Guru Gyaan. And Gyaan is given by our Guru, which is Dr. Aniruddha Kulkarni sir. And the second session will be held on 3rd of April. Then going further, we will have the second session on 1st of May. And our last session will end on 5th of June. So this is the program. Before that, let me introduce to you once again our Nuewa I9 Elite Edition. And according to our topic, I will give you few technology update, which will give you what solutions we have to offer you for the gynecology applications. So as I say, Nuewa I9 last time as well, that it's a full stack intelligent solution for the woman's healthcare. Starting from the pre-pregnancy to the pregnancy and postpartum, we have the solution for each and every applications. So whether you have to do a transvaginal probe scan, whether you have to do the volume convex probe scan or the convex probe scan, or you have to scan the postpartum, which is either you have to do the pelvic floor scan. So we have the solution for each and every applications, each and every stage of the woman. We have the intelligent solution for them. So for the gynecology as the topic itself, I would like to give some insights on the what doctors needs in gynecology. So they need to do the evaluation of the fallopian tube, or they need to do the evaluation of the ovarian evaluation, as well as the main thing lies at the uterine evaluation. So for that, we have the two probe solution, which is high frequency volume TV probe and high frequency the normal TV probe, which is high density probe. So both have the very good angle as well as the wide angle probes, and this gives you the fantastic 2D resolution. Along with that, if you are doing the scans with the volume TV probe, because of the ZST Plus platform, it gives you very accurate as well as very fast 3D scans. So if I'm talking about uh this thing, the trans vaginal scan, then when we are doing the uterine evaluation along with the 2D evaluation, we also need to do the blood flow perfusion scan. So for that, we have the normal color flow, we have the HR flow. Over and above that, we have the glazing flow, and now we have introduced the ultra microangiography flow, which gives you the finest vessels. The details of the finest vessels will be given very nicely with this ultra microangiography flow. And on that ultra microangiography flow as well, we have the glazing flow, so which gives you the 3D visualization of the color flow. And your vessels will not overfill. It will be inside the vessel, inside the lumen, the color will be filled very nicely. So this is how the difference is. So for the TV probe, we have to have the PRF very low and the scale has to be very low. So for that, the sensitivity is the issue in normally many of the equipments. But here with the ultra microangiography flow, you can pick up all the tiniest vessels very nicely. You can see the how super sensitivity it is showing in the perfusion of the ovaries. So coming to the 3D 4D part, so the when you are doing the uterine evaluation, of course you will do the 2D scan, and then 3D 4D plays a very important role, because in the 2D you cannot do the coronal plane scan of the uterus. So for getting the diagnosis of the uterine malformation, the 3D 4D becomes very essential and vital part of your scan. So for that, when you put your probe on the screen, when you do the scan, what you all need to do is you have a rendering box. You need to adjust that rendering box. That rendering line needs to be adjusted, and it has to pass through the endometrium to see the uterine evaluation of the endometrium. So this is how this thing will happen, and you get this kind of image on the screen, and then you do XYZ rotation, and then you see both the cornuas, and you will be able to see the nice uterine 3D 4D scan. Then over and above that 3D 4D, you have the slice contrast view with the curved multiplanar rendering, where just by drawing one line, you get the coronal section of the uterus. So this is how the complete 3D 4D takes place. But now in Mindray, we have this solution which is AI based for the uterine evaluation. So again, this is Smart Scene 3D, and so many times I have spoken on the Smart Scene 3D. This is fully AI based solution. You just put your probe in the uterine cavity, machine recognizes that this is the uterus, this is the endometrium, and it will give you the rendering line automatically. It will do the rendering for you, optimization for you, and over and above that, it will also give you the coronal plane, endometrium thickness, and it will scope out the endometrium volume for you. So all these things, whatever I have spoken, will take place hardly in 1 or 2 seconds. So whatever manual things you do, and which takes around 5 to 10 minutes time, this will happen in just 2 to 3 seconds. And if you want to get the vascular information, you want to do you want to check the receptivity of the endometrium. So when you are doing it, when you are acquiring the volume with the color flow information, it will give you VI, which is vascular index. It will also give you the flow index, and it will also give you the vascular flow index. So this entire thing will hardly take 2 to 3 seconds. So that's about the AI that we have incorporated in our Nuewa I9 Elite Edition. These are some of the fantastic images done by our TV volume probe, as well as TV normal volume, normal TV probe as well. And you can also get this follicle count automatically. You can do the eye page, which is the tomographic ultrasound imaging, slicing of the volume. You with this, what I have spoken about, the ultramicroangiography, the tiniest vessels will be picked very nicely. This is the 3D 4D, along with the iLive, which is your photorealistic image, and along that we also have Hyaline, which gives you the transparency view. We also have the solution for the hycosi, the patency of the fallopian tubes. The solution is 4D hycosi along with Hyaline. So with all this, we have the fantastic solution for the gynecology, and along with that we have for obstetric, urogynecology, as well as the fertility. So today just I have focused on the gynecology, seeing the topic. So this is about the full stack solution. After session also, if anyone wants to get connected, we have our team, they can have the inquiries also done for this product. So, without wasting any time, we all know sir, but it's a pleasure for me and to introduce him once again. So, we are really very honored and very thankful to Dr. Aniruddha sir, who is our esteemed speaker for this session. He is a renowned radiologist and, of course, a great educator. He serves as a president of SFM Marathwada. Along with that, he is a founder of Scholar MD, founder and director of Scholar MD. We know he is a fantastic teacher. He is a national and international faculty. So we welcome you, sir, for this excellent, well-curated session, which is designed by you. And along with sir, we also have Dr. Mahesh Tandale, who is a distinguished obstetric and gynecologist. He is also a professor in Department of OB-GYN in IIM Maharashtra. And he carries vast experience of 20 in this field, and he's a respected mentor in his field. So we welcome you, sir, as well. So I will hand over the session to Aniruddha, sir. Over to you, sir.
Thank you. Thank you, Viraj. It's wonderful to see that many people are having a lot of interest in gynae ultrasound, because we know most of the people, they like to go for fetus and MSK. That's the trend nowadays. It's good to see more and more people want to learn out something new.
Close to 200 people have already joined, sir. Yeah.
Yes. So I hope my screen is seen well.
Yes, sir.
And my voice is not cracky, or I'm audible clear.
Absolutely.
That's
Yes.
that's fine. So thank you once again. Just to add on to Dr. Mahesh Tandale, Dr. Mahesh Tandale, who is a very great human being and friend of mine. I learned great as far as the gynae ultrasound is concerned from him. A wonderful clinician, always believe in imaging science, try always give inputs post procedural to the clinician to the clinical radiologist, expects more and more from the imaging team, and always there to help most of the imaging people. So thank you, Dr. Mahesh, for being with us for years together. Today we'll be discussing about acute pelvic pain transvaginal evaluation. My name is Dr. Aniruddha Kulkarni. Wherever I have taken some literature into help properly acknowledged images, mostly are from my imaging center, one or two which are not from mine will be acknowledged duly. Mainly, we'll be dealing with ultrasound first and category of pelvic pain. We'll touch upon acute as well as few of the common etiologies of chronic pain. We are more concerned about acute pain because it is closer to 30% of our OPD work. It's quite disturbing for the female as well as for the entire family. It hampers the work output of the female as well as the family. On many instances, the cyclical pain can be of a psychiatric grade concern, which may eventually lead into chronic pain. And because of diagnostic dilemmas, the acute and chronic pain, they are landing up for a lot diagnostic laparoscopies on many centers. What we can say, demanded hysterectomies are done to get rid of that pain. We have three modalities: ultrasound and color Doppler, CT and MR. Availability is the issue in the rural part as far as CT MR is concerned, but ultrasound color Doppler scores very high as compared to other, being dynamic and interactive. These females, they land up into physician, pediatrician, surgeon, or gynecologist chambers. And depending upon the clinical symptomology and scores, the modality of investigation is considered. We consider the pain to be acute when it is intense, sudden one. It is non-cyclical, lasting for more than 6 months, hampering functional ability of that female. It's a chronic one, which requires medical attention and treatment. A cyclical one, which is associated with mensen and typical cyclical in nature because of severe dysmenorrhea. So acute pelvic pain may be associated with fever, nausea and vomiting, blood mesoleucocytosis, vaginal bleeding PV, or some foul smell discharge can be there in few individuals. The causes can be gynecological causes, obstetric causes, GI causes, genitourinary causes, other causes pertaining to vascular MSK and anterior abdominal wall involving lower abdominal cavity. Early pregnancy, non-viability issues, extrauterine pregnancy could be the causes common for the obstetric variant. When we ask for ultrasound CT-MR, ultrasound is imaging investigation of choice. This is a figure that we learned in second MBBS. So everything from gallbladder fossa to left iliac fossa, from spleen, tail of pancreas to umbilical region and right iliac fossa, all the intra-abdominal organs can give rise to infraumbilical severe acute or chronic pain in case of a female. In terms of causes, we can broadly categorize as the gynecological causes and non-gynecological causes. The non-gynecological causes could be appendicular, appendicitis, diverticulitis, lower ureteric calculus disease, bowel ischemia, particularly in case of pediatric age group of patients. Mesenteric adenitis, again in case of pediatric age group of patients. In certain patients with ulcerative colitis and Crohn's disease can present as acute symptomatology. Post-operative collections, particularly after the post-laparotomy or post-sections. The gynecological causes could be ovarian cyst or cyst rupture, tube ovarian torsion, isolated torsion or ovarian cyst torsion, pelvic inflammatory disease, symptomatology, and different four variants. Endometriosis variant, we do have a dedicated talk on endometriosis, so I will not go into much detail as far as endometriosis is concerned. Sometimes large size fibroids or degenerating fibroids can cause acute pain. Any woman who can be pregnant at this juncture. Hence, it is always better to rule out obstetric causes as well. Appendicular perforations, acute appendicitis is very common. You can accidentally see appendicitis even on transvaginal ultrasound. So appendicitis may go to tube or vice versa. It may eventually post perforation lead to pelvic abscesses and peritonitis. Diverticulitis involving the colonic region, classically describing as a colonic edema with along the outpouching and a tiny hyperechoic area over there, can be a feature. And these beautiful images are given to me by Dr. Ravi Kadasne. Epiploic appendicitis even can cause, which is classically described as a fat area of epiploic appendicitis, which is showing extensive edema changes adjoining to the same. In case of pediatric age group patient, you can see there is a small bowel, extensive edema. Along with that, there can be a fat standing or even peritoneal thickening in few individuals. And we also should rule out the ischemic bowel in case of pediatric age group of patient characterized by exuberant small bowel edema with thumbprinting involving the bowel wall, which is a classical description of ischemic bowel. We know that ulcerative colitis in which the mucosa and submucosa is involved. Here you can see the serosa is preserved as a hypoechoic area, but you can see exuberant edema involving mucosa and submucosa. In case of a Crohn's disease, you will get a pericolonic fat standing along with enlarged edema. And here in case of Crohn's disease, it's a transmural edema. That is from the serosal surface up to the mucosa, submucosa, everything is involved. And to differentiate between ulcerative disease and a Crohn's disease, primarily, it's inflammatory disease where in case of Crohn's, there is a backwash ileitis. It may be associated with strictures and fistulae. And because of transmural occurrence, crypt and crypt abscesses are more common in case of Crohn's disease. Hence, acute symptomatology may be known in case of a Crohn's disease. Lower ureteric calculus disease is not uncommon entity. We can see transabdominally, but on many instances, you can search for those calculi by doing transvaginal ultrasound, by looking for specific area of vasoaortic junction and tracing it, the lower ureter up above, more towards the crossing of iliac vessel. That's the mid-ureteric entity. In patients with diabetic mellitus, which shows severe degree of sepsis, there is a marked cystitis in this patient. But not only that, you can see that the entire course of ureter on the right side is dilated and there is a moderate hydroureter necrosis. The collecting system also has a coarse debris echo, which is showing again a continuation into upper ureter and also reaching well up to the vasoaortic junction onto that side. So urological sepsis may present as a ureteric stricture involving lower one-third, giving rise to acute symptomatology. In case of acute pelvic pain, which can be because of functional ovarian cyst, pelvic inflammatory disease, or torsion variants, non-neoplastic ovarian cyst could be follicular in nature, which are anovulatory, enlarged one. There can be a enormous corpus luteum, because of which there is enlarged ovary along with ring of fire sign, or it may get collapsed on occasions, giving rise to regression of the corpus luteum. And in case of advancing pregnancy in early pregnancy origin, the corpus luteal support may get lost. You may get theca luteal cyst, which again may be common with the gestational trophoblastic disease or multiple pregnancies. They can remain there for a little bit of longer period of time as compared to corpus luteal cyst. Whenever we are considering functional ovarian cysts, they can be large size, more than 2.5 centimeter. They can have an indwelling hemorrhage within the same, and this rupture and leak of thin vessels may give rise to what is classically described as a fishnet appearance or a clogging type of a clot within the ovarian cyst over there, which can be a retractile one. So ring of fire sign, which often is mistaken as the ectopic pregnancy in that region, always should be considered as the last resort to label it as ectopic pregnancy. You can have a little bit of septation in case of clot areas. Whenever you give a sustained pressure transvaginally, the clot will giggle, but the solid ovarian tumor-like tissues will not giggle, and fishnet appearance in case of ovarian cyst is quite common. Whenever there is a rupture of hemorrhagic ovarian cyst, the patient will have severe pain. On many instances, can have a hypotension, and more or less by excluding the other causes of severe pain and hypotension, we can attribute it to be rupture hemorrhagic cyst. You can see the collapsed deformed cyst, which may show some features of vascularity within the collapsed wall, and there can be hemoperitoneum. Now, this is a classical collapsed corpus luteum cyst showing feature of a ring of fire sign on color Doppler and a power Doppler. Now, on many instances, there can be ovarian enlargement, and there is a pre-existing ovarian hemorrhagic cyst now develops into ovarian clot-like area. Along with that, a small amount of collection can be seen adjoining to the ovarian parenchyma in the respective compartment as well as in the POD. On many instances, there can be typically thin-walled, smooth marginated Morgagni cysts. They are typically unilocular cysts, which are simple, which predominantly moves independent to that of ovary with when the transducer pressure is applied, and they can be better defined whenever you try to do a bimanual examination. Such cysts, when they get secondarily infected, or they have what is called as a ground glass appearance because of the presence of an endometriotic tissue in adjoining component, can give rise to severe acute pain in the respective area. Pelvic inflammatory disease is a form of upper genital tract infection. The incidence is on rise, may predispose to infertility in due course of time, or may get converted into chronic debilitating pain. It is typically a sexually transmitted disease on many instances. On many instances, it could be post-procedure like DNC or instrumentation like IOCD insertion. These patients, they present with abnormal cervical discharge, fever, leukocytosis, signs of sepsis in the form of severe tenderness on per vaginal examination, and even on transvaginal ultrasound examination, cervical adnexal tenderness can be appreciated. This PID in the literature has been described into various categories like endometritis, myometritis, where on occasions the ultrasound features may be normal, salpingitis eventually leading to pyosalpinges or hematosalpinges, tubo-ovarian complexes where a distinct normal or abnormal looking ovary can be still seen in the adnexa of a tubo-ovarian complex, tubo-ovarian abscesses where because of the adnexal location, we say it's a tubo-ovarian mass or abscess, but distinction it into a salpinge or a ovary may not be possible on instances. There can be air reverberation echo within the substance. Now, endometritis is quite age-old senior loop that I have stared when I was having GE for that machine. Most common variant is endometritis, myometritis. The ultrasound can be normal. You may get a thickening of endometrium on occasions. This was a patient in which the MTP was done recently. You can get a raised vascularity involving the endometrium and adjoining myometrium. There can be complex collection within the cavity along with the debris echo, which is a typical feature of a post-MTP sepsis within the cavity. We'll see one or two slides in due course of time. There can be gas reverberation within the cavity, which is a feature of aggravating sepsis. The sensitivity in labeling it to be myometritis or endometritis on clinical appearances is more reliable than ultrasound features per se. The next variant is a salpingitis or a pyosalpinx. You will get a thickening of the tube with raised vascularity. The tube is elongated cystic area. Sorry, it will have a multiple partial folds. There can be a nodular enlargement of a beaded cogwheel appearance on a transfer or axial fashion. It will have a peripheral vascularity on occasions. This is classical hematosalpinx. You can see partial septi, which are arising from one wall, not reaching to opposite side. Here you can see a part of the tube which is thickened on that side. This was a hematosalpinx, but eventually turned into a pyosalpinx in due course of time. Now here you can appreciate the tube elongated one can be seen as a thickened area, and within the tube you can appreciate a coarse low level debris echo mimicking that of a blood component. But depending upon the clinical symptomatology, we thought that either it could be hematosalpinx or a pyosalpinx. When we do a rendering on 3D, you can appreciate the multiple folds of the tube very well along with the degree of sepsis on colored of that. On many instances, when the indwelling sepsis is high, you may get a bilateral pyosalpinges in cases of immunocompromised host. Here you can see on the right side, there is a pyosalpinge. On the left side, also a retort-shaped lesion. Along with that, the tubal thickening and coarse debris echo within the lumen, which is a classical description of pyosalpinges. This was a 35-year female with increasing left iliac fossa pain, retroverted uterus. And the reason why I want to show is that there is no examination is complete without transvaginal examination. So this will show that nothing is there in the pelvis which is of diagnostic significance. You do transvaginal ultrasound, you apply your 3D sequences over that, and you realize that you are looking after some kind of a tubo-ovarian areas, which is having air reverberation echoes and a feature of a tubo-ovarian abscess. So this is a tubo-ovarian complex of the same patient. Here, you can appreciate that. Can you see this tube which is enlarged? It is inseparable from a ovarian looking component which is peripherally placed over there. These are tube ovarian complexes. They are inseparable from the ovary. Ovary is indistinct, hyperemic, and edematous. This is a classical chronic tubo-ovarian mass, but the etiological factor was ectopic pregnancy. Here you can appreciate there is a raised vascularity. Along with the tubo-ovarian mass of chronic ectopic region, you can appreciate that there is some amount of collection within the POD on the left side. Tubo-ovarian abscesses, it is because of the breakdown of the tubal wall rather than the ovarian component. The ovarian ecotexture gets distorted. There is a heterogeneous complex mass. You may get a fluid kind of a level or air reverberation echoes. Adjoining areas will show thickening of peritoneum in the form of peritonitis, lot of tenderness. And bimanual examination will show restricted movement in the respective size and eventually can have a pelvic abscess motion. Here you can see a large pelvic abscess, which is because of the ovarian abscess. Now here you can appreciate a small portion which is of ovarian-like on the right side, but at the same time a right tubo-ovarian area. Adjoining to that, I can see some fat edema changes and aerosolvation recurs over there. Torsion is one of the common entity and most of us are worried about. There can be adnexal torsion involving tube, ovary, or in combination or in isolation. On rare occasions, there can be a subserosal exophytic fibroid going into the torsion. The ovarian torsion, there can be history of cyst in recent origin. There can be history of some laparoscopic surgery, pregnancy, ovulating drugs. It is more common in adults. The ovarian other lesions needs to be discriminated are from the benign lesions. On many instances, the teratomas also can get under torsion. It's typically a sharp stabbing kind of a pain associated with nausea and vomiting. The features of peritoneal irritations are quite remarked in case of tube ovarian torsions. But always remember, the salvageable ovary percentage is less than 20%. And it is missed on clinical grounds as well as ultrasound ground because of so many equivocal findings on many instances. So ovarian torsion, when you should have a high degree of suspicion, whenever there is a asymmetrical enlargement, that so one ovary is absolutely normal looking or small, other ovary is enlarged, the size is more than 5 centimeter, there is a massive vascular, massive ovarian edema. The volume on occasions can be more 3 to 4 times, up to 20 times. And whenever you see that there's asymmetrical involvement of one ovary due to massive edema, massive enlargement in contrast to normal looking other ovary, always have a high degree of suspicion of ovarian torsion. There can be a lot of tenderness with fluid collection adjoining the ovary and the POD, and peripheral anterior follicular ring sign, which is because of the compression of normal or abnormal small tiny pericles pushed laterally towards the peripheral rim is a description. Torsion in normal ovaries can be appreciated in case of neonates and kids. Mobile mesosalpinges on many occasions can be responsible for the same. Now, there are various spectral Doppler features which can be attributed to torsion. Torsion in our back of mind says no flow, but that's not the case. There is an obstruction of lymphatics because of torsion, which leads to obstruction of venous component first, which leads to massive ovarian edema in contrast to normal looking other ovary. And later on, there will be arterial occlusion and obstruction because of venous superior amount of huge ovarian edema because of venous congestion and venous obstruction and then arterial obstruction. So on many instances, there can be reduced arterial supply and still maintaining venous supply. On instances, there can be erythema of ovarian tissue showing features of hyperemia in arterial component, and very rarely you will find arterial and venous component completely absent. So equivocal finding on many instances can be there. We need to give more importance to asymmetrical huge enlargement of ovary with massive edema. Okay, so normal, the finding could be normal, diminished or absent flow, increase resistance or loss of diastolic flow. So whether there is edema or no edema will have more significance rather than isolated finding, because initially there will be lymphatic obstruction, venous obstruction and arterial obstruction. There can be dual flow, that is a reduced etiology of arterial and venous origin in case of many diseases where there is a ovarian torsion. Okay, so here you can appreciate there's a massive edema where the ovarian volume is more than 25 cc. This is a transabdominal ultrasound, and here you can appreciate the peripherally located tiny ovarian antral follicular ring sign. And if you are fortunate enough, you can appreciate. Can you appreciate this classical whirlpool sign here? So whirlpool sign can be appreciated on grayscale ultrasound as well as on color Doppler. Okay, now here you can appreciate that there is a whirlpool sign over there. And here you can appreciate there is ovarian cyst. So ovarian cyst along with ovarian torsion in this patient and classical features also explained on laparoscopy. Here, now let us take the example. Look at this massive edema. Look at this massive edema. peripherally pushed out tiny follicular ring sign, and classical feature of whirlpool sign in respective adnexa gives you a perfect diagnosis of ovarian torsion. On many instances, there can be a cyst along with the ovary with cyst torsion, or there can be a tubal torsion. Here you can see that there is a massive enlargement of the tube along with the ovarian torsion, lot of collection within the pelvis, and on laparoscopy it shows that it was a tubo-ovarian torsion along in which the tube was showing features of hematosalpinx. Now, this was a very interesting patient. Here you can appreciate it's a postmenopausal female. Small amount of collection was noted within the uterine cavity, but the patient was having very acute, severe, agonizing pain. The age of this patient was 95 years age group. Now look at the right ovary. Here the right ovary looks to be very small. But what about the left ovary? Now this left ovary was massively enlarged. Here you can appreciate the massively enlarged ovary. But I was not sure in case of 95-year female, how can I label it to be a torsion? So when I took a Doppler, now here you can see 90 years age, postmenopausal female. Now here you can see the ovary, which is massively enlarged in that patient. I can still show some amount of vascularity within the substance of the ovary. So I was not sure. So I just label it to be a asymmetrically hugely enlarged ovary on one side. Other ovary was normal in a postmenopausal female. On laparoscopy, this ovary was removed and eventually it turned out to be early features of solid ovarian mass within the same, and it was ovarian malignancy. So probably it was ovarian malignancy along with the torsion on left side in this individual. So Pearl, flows suggest viability and do not exclude torsion in those individuals. Two symmetrically looking ovaries, you are absolutely ruling out the ovarian torsion. So negative predictive value of this sign, that is symmetrically normal looking ovaries on both sides, rules out ovarian torsion. A disproportionate clinical sign and no ultrasound features in which one ovary is remarkably enlarged always have a high degree of suspicion as far as ovarian torsion is concerned. Ovarian vein thrombosis can be seen in case of postpartum patient, in case of obesity. It is more common on right side, but it's again a diagnosis more on CT rather than ultrasound. You will hardly get some kind of a clue in case of ovarian vein thrombosis. Fibroids can lead to some degree of acute or chronic pain. They can be cervical fibroid, submucous fibroid, pedunculated fibroid, which can go twists. There can be fibroid showing degeneration in the form of hemorrhages, infarction, and so on. On many instances, even the huge size of the fibroid per se can compress the adjoining normal structures and can cause a pain. On many instances, pregnancy in relation with the placenta can have acute pain because of some or the other effects over the placenta, or there can be rate degeneration changes within the placental tissue and showing features of cystic changes within the placenta, which may have increased vascularity and features of sepsis. There can be cervical mass. Here you can appreciate the endometrium to be normal. There is an echo dropout area at the level of internal os. But here you can see there is a large mass within the cervical component. It was a submucous fibroid polyp now coming into the cervical region. So endocervical mass pulling the fundus of the uterus way down at the level of introitus can be a feature of acute pain on many instances. Here, same patient. Can you see a echo dropout area over here? That's the anechoic area, a large mass over there. And that's the cervical fibroid, which was causing acute pain in this individual. Endometriosis, I will not go into much of the details. Adenomyosis can give us to acute pain or cyclical pain. Ovarian endometrioma, increasing size or sudden disappearance may cause acute pain. Deep infiltrating endometriosis can have a severe degree of pain because of involvement of uterosacral ligaments, because of involvement of the pouch of Douglas, and even the ligaments of the pelvis, and the lower ureteric involvement or the higher involvement above the pelvic brim can have a acute pain. Bowel and pressure pelvis with deep infiltrating endometriosis is not uncommon. In case of acute pain, in case of pediatric age group, can be because of torsion, functional cyst, vaginal foreign bodies, obstructive lesions like hematometra, hematocolpus, labial lesions, which can be because of the, the inguinolabial hernias, PID, or ovarian vein thrombosis. Again, in those individuals, urological, bowel inflammatory disease, and GI can be common. Let us take this example. There is a asymmetrical thickening of the vaginal fold over there in this young kid. And here, what do we appreciate? There is a herniation, and the content of this herniation was an ovary. And there was a lot of tenderness and redness which was seen in this patient with a severe pain. Just to enumerate some of the causes of chronic pain, acute causes of endometriosis, adenomyosis can lead to chronic cyclical pain. Pelvic varies in case of acute congestion syndrome. Acute pelvic condition can be a chronic etiology. Malposition IUCD that we have seen in last session can be cause of chronic pain. Inflammatory bowel disease can from acute to chronic entity can. So here is a classical description of adenomyosis. Interrupted endomyometrial junction, islands, streak sign, asymmetrical thickening of one or the other wall, IUCD with adenomyosis changes, a classical appearance which is beaded appearance of endomyometrial junction in case of adenomyosis. Typically, we say clinically it's a tender uterus on palpation because of adenomyosis and pelvic congestion. This was an interesting patient in whom for endometriosis surgery was done, ovary was removed, and still, can you appreciate the sutural landmarks over here? These are the hyperechoic reflective areas which are not calcification in fact, but the sutural and the clipped area of the right adnexa. Now, within that area, you can appreciate now the endometriotic deposit which is there, which we label it as the ovarian remnant syndrome in the respective area. So ovarian remnant syndrome can be unilateral or bilateral after the ovarectomy. The fragment of a normal or some part of active component of ovary which is remaining get encased by the fibrosis with repeated attacks of endometriosis deposits there can lead to a cystic formation and acute or chronic pain. This we have seen already in the last normal or abnormal positions, that is expulsion, displacement, embedment, penetration, and fragmentation, out of which embedment and penetration can cause acute as well as chronic pain. Cyclical dysmenorrhea of primary or secondary in nature also can be feature of acute or chronic pain. Secondary dysmenorrhea because of endometriosis, adenomyosis, and IUCDs are not uncommon. And there are certain etiologies on many occasions can be diagnosed on the first go on ultrasound. That is mullerian obstruction, ACM, uterine adhesions, fibroid, and pelvic congestion. Now, this is the classical. We did SIS, saline infusion sonography in this patient. We can appreciate a fluid within the endometrial cavity, which is showing interrupted areas of the myometrial tissue reaching from one space to other. That's a classical description of uterine adhesions. Accessory cavitative uterine mass, these are nothing but juvenile cystic adenomyoma. It is at the level of insertion of the round ligament below the insertion of interstitial tube portion of the tube. Abnormal contour of the uterus, which is classically seen on 3D or transabdominal ultrasound, giving rise to severe dysmenorrhea. Sorry. Now, all these senior lobes will show you features of, you can appreciate that there is a hyperechoic area at the right corner. Here again, you can see a small collection along with the myometrial rim adjoining this area. Here you can appreciate a hyperechoic area. This one of my colleague labeled it to be ectopic pregnancy of interstitial nature, but in fact, it was an actum. Mullerian obstruction in case of pediatric age group, maybe because of imperforate hymen, lower tract hypoplasia or agenesis or transvaginal septum. Now, here you can appreciate that uterus is having small amount of collection there, but the lower part of the cervical canal reaching up to the vagina is showing features of hematocolpus. Now, in this patient, you can see a normal contour of the uterus over there. I can see a cervical portion over there, but I am unable to demonstrate anything like a vagina transabdominally. So I decided to go ahead with a perineal scan. Now, what do I demonstrate on the perineal scan? Now, here, can you appreciate the anal canal? Yes, I can. So now here, this is the anterior wall of the anal canal. This is the posterior wall of the anal canal. The anterior wall of the anal canal is in close proximity of the posterior urethral wall. And because of sustained pressure, also, I am unable to create any kind of a space between the urethra and the vagina. Urethra and the anal canal, sorry. So in fact, we are dealing with vaginal agenesis. That's not uncommon. So here, you can go ahead by performing a consented transsectal ultrasound with a thin transducer, and then you can demonstrate that, yes, I can see a cervical canal there. I can see a small collection involving the uterine cavity over there, and that is nothing but a vaginal agenesis. So perineal ultrasound is a key feature which needs to be sought in most of the patients of pediatric age group of acute nature, where you are looking for any variants of lower tract obstructions. Uterus and cervix post-cervical electrocoagulation can have severe degree of pain because of obstruction causing cervical region. So typical approach to pelvic pain on imaging could be, if it is an acute one, try to look for obstetric causes, look at pregnancy test, urine pregnancy test is positive, look for ultrasound. Still along with normal pregnancy, if you are looking for any kind of a acute abdominal bowel etiology, go for MR rather than going for CT. If the pregnancy test is negative, go for CT or MR. That is as far as the non-obstetric causes are concerned. In case of a chronic pain, ultrasound and MR. And in case of acute pain, we have seen all the gamuts of transvaginal ultrasound in earlier. So if it's a cyclical nature, look for the causes of primary dysmenorrhea, secondary dysmenorrhea. In case of a primary dysmenorrhea, where no anatomical findings are seen on ultrasound, there is no imaging probably is required. In case of secondary severe dysmenorrhea, probably you will require ultrasound and MR. So this was a very interesting patient, missed menses, intermittent pain, and spotting on right side. What do I find? I am unable to define anything in the adnexa, a very diffuse mass which was seen. The uterus was completely empty and retroverted in nature. What I can only say was there was a right tubo-ovarian mass which showing some degree of vascularity. Now, can you appreciate now? The left ovary seems to be normal, but on the right side, on some areas, I can see that probably there are some ovary-like features there, but there is a mass which is there, a lot of tenderness which was there already, but I was not very sure. So I decided to label it as a tubo-ovarian mass, but in fact, it turned out to be a tubo-ovarian abscess, but on histopathologically, it turned out to be a chronic ectopic with some amount of chorionic tissue which was demonstrated. So retrospectively, when I look at the lesion, now I can say that yes, probably this was the area which was nothing but area of a gestational sac, which was a chronic collapsed one with some amount of appreciable yolk sac-like feature within the same. So I reported it to be right tubo-ovarian mass, lot of tenderness, likely to be tubo-ovarian abscess, but on laparoscopy, it turned out to be a chronic tubo-ovarian mass secondary to ectopic pregnancy. So that was what was the missing. Probably I didn't look very closely to this small anechoic portion within the center of that lesion, which was mimicking to that of some gestational disease pattern. Thank you very much for your patient listening. I'm stopping my screen sharing, and I now request Dr. Mahesh Tandale to show us some light as far as clinical background and probably what are his expectations whenever he says that it's acute pain, or he's demanding some kind of imaging finding from clinician on acute pain as far as the case under clinical trial. Dr. Mahesh, please.
Yes, sir. Thank you so much. Am I audible? Am I audible?
Yes, you are audible, but we cannot see Dr. Mahesh.
Okay.
If possible, you can start your video as well.
The video is on. That's still okay, sir. What
Okay.
I wanted to tell you, the important message you are given, whether pain is you're suspecting a gynecological or non-gynecological. First important thing in all three segments you have written is pregnancy needs to be ruled out. So every radiologist should understand that whatever the age, like your last case you have shown, the age is 48 years, woman.
Yes,
You
yes.
will not even think of pregnancy sometimes. So first, any woman of a reproductive age group from her menarche till menopause, a pregnancy needs to be ruled out in all instances, regardless of status of woman, considering she can be pregnant at any time. You have a first sentence to be written that someone who can be pregnant anytime. So
That's right. Perfect.
so not only believing on the urine pregnancy test, we should always write down that beta HCG needs to be correlated when you're suspecting any acute pelvic pain where the findings of ultrasonography are suspicious. Second important, when you're evaluating a clinical cases where there is adnexal masses, ovarian cyst, hemorrhagic cyst, and suspicious of torsion. clinical history is at most important. If they have just written pelvic pain and ultrasonography to be requested, we should call the clinician and ask about the detailed history, including the history of fever, including history of pain, including history of abnormal vaginal discharge. Because these important findings, one cannot only based on a sonological finding, cannot go and diagnose one thing. It has to be correlated clinically. Unless and until you have a clinical background, unless and until you have a clinical support, you cannot make a decision what exactly this could be. Like one, it could be a TO abscess, it could turn out to be chronic ectopic. When you're suspecting, like you're shown one case where you can see a cyst, hemorrhagic cyst or simple ovarian cyst, but sidewise you can see a ovary which has got torted, a normal looking ovary which got torted. And most of the times these are like ovarian cysts which got ruptured, ovarian torsion which are mostly a partial torsion, or where you can write down, maybe we're going to discuss about iodine next time. So we'll stop writing down that complex hemorrhagic ovarian cyst. And that's why when you have a hemorrhagic cyst with a pain, so where first clinician will demand that whether it is a torsion or not. So important message you are given that no flow does not rule out the torsion. Even a presence of flow could be a torsion. So that you have to understand. From clinician perspective, you should understand that every ovary will not give you all Whirlpool sign. Every ovary will not, torsion ovary will not give you Whirlpool sign, because it could be in initial stage where ovary can be salvaged. Intervention can be done. And for every patient with acute pelvic pain, we cannot directly jump that laparoscopy has minimal invasive surgery has become so safe. We cannot jump in doing each and every case with laparoscopy. Likewise, we have endometriosis, like deep infiltrating endometriosis, which is coming, a new entity. We have like acute cases coming up. We have Mullerian cases. So where the ultrasound is the key, that you need to evaluate the adnexa, you need like the vaginal agenesis you have shown, that unless and until you see, even MRI can give you a canal, vaginal canal is normal, and you end up doing like it is a low transverse septum, you end up doing dissection and you end up doing nothing, and you're again posting a case for another surgery. So ultrasound evaluation in a sequence, in a systematic fashion is very important, with the background of a clinician helping a sonologist for making a diagnosis.
That's perfect, Mahesh. So just to take this discussion further, now, usually whenever I speak on most of radiological meetings, I always say that the quality of imaging entirely depend upon the question posed by the clinicians. The more and more questions which are asked on the reports that I produce for a clinician, then only then I realize that there are so many things need to be seen in those patients. I mean, I have learned over a period of time because of Dr. Gadappa and many wonderful clinicians that you can do transsectal ultrasound when the transvaginal ultrasound is not possible. You should look for the above the brim entities when the patient is having acute pelvic pain. Nowadays, the problem is where does the patient lands? I mean, if the patient lands with the physician, probably the ultrasound expectations are like enteric fever, then the mesenteric adenitis. If the patients they land up with the laparoscopic surgeon, then I am more keen into say whether I have a appendicitis or whether I have if the patient of a pelvic pain come from a urologist, then I will start looking for the calculus. So it's very important for an imaging person to understand that the the pelvic pain, acute origin, or a cyclical or a non-cyclical nature, the cause of the pain can be a huge differential. I mean, you cannot just look for calculi, just look for appendicitis, just look because it is coming from gynecologist, look for ovarian in nature. You need to look this as an entity where the pain can be there, anything from the below the Ziphy sternum. And that approach needs to be there. So I always tell most of my PGs is that talk to the patient, just try to dig out some of the older histories that you can dig from the patient. It's very, very important. So I just want to ask Dr. Mahesh one thing is that how often the only transabdominal ultrasound is tolerable. I mean, on many occasions, it's very surprising that patient they deny for transvaginal ultrasound because of ABC XYZ reason. But I want you to give a clear-cut message that whenever transvaginal or transrectal ultrasound is possible, the imaging finding that an imaging guy can give on these two modalities cannot be matched with any transabdominal ultrasound. I just want to hear something which is quite encouraging for all my imaging fidelity. Dr. Mahesh.
There is no doubt. There is no doubt. The only transabdominal ultrasound cannot give you all the information what is required for a clinician. So that is important thing. Unless and until you're going to evaluate all the possibilities, unless and until you have all whatever gadgets you have to exhaust all your gadgets to reach to the diagnosis. That is important. So doing only a transabdominal, like your case of postmenopausal, which turned out to be ovarian cancer, unless and until you have evaluated with transvaginal, you could have missed out that ovary. So without doing a transvaginal ultrasound or transperineal ultrasound or transrectal ultrasound, you cannot even a simple case of painful bladder syndrome, interstitial cystitis can present like anything. That can be treated by various of surgeon, gynecologist, urologist. But unless and until you evaluate them, you're not going to go to the conclusion. So just only a transabdominal ultrasound is absolutely incomplete when you're at least talking about a pelvic pain in a female. Because that could be gynecological causes, that could be non-gynecological. As you said, anything from zipis sternum can come down to the pelvis as a symptom of pain. So it is very important to do a transvaginal scan, investigate for adnexal masses, investigate for all possible causes. That is
That's
most important.
That's very true. I mean, see, I started looking for ureteric calculi because I was working with Dr. Abhay Mahajan for a very long period of time. Then I realized that the lower one third, as the ureter they crosses the iliac brim and crosses the iliac vessels over there, the lower one third can be seen so beautifully on transvaginal ultrasound. Now I have stopped looking for them transabdominally. The moment I put a transvaginal transducer, including the presence or absence of a stricture, degree of sepsis, along with that, the pressure effect of the calculi that I can see on transvaginal ultrasound. Absolutely, I mean, they are just like CT images. So I always feel that the transvaginal ultrasound or a transrectal ultrasound in indicated patient should be used just like a clinicians they use their own finger to assess the gynecological pelvis. I mean, it's really wonderful magic imaging modality, no doubt about that.
And if woman is ready to be examined by a gynecologist, I hardly seen any woman who's not been ready for a transvaginal scan.
I agreed too.
Once
Let us
once
take
they've been referred for a pelvic pain, that means there has already been underwent a per speculum or per vaginal bimanual examination. So once you counsel them, give them a comfort, there almost every woman will be ready for a transvaginal scan.
Yes. Viraj, can I take those few questions which are there in the question answer box?
Yes, sir, please. Yes. So you
Dr.
want me
Mahesh,
to note or you will answer them?
no, I will directly answer, no problem. There is one attendee who says, case of ovarian cyst more than 5 centimeter, how to calculate ovarian volume? See, usually we should mention both the things. I mean, if it's acute pain, I would like to go ahead and see what are the cyst content, what are the cyst wall area over there, and I will calculate a volume of ovarian cyst as well as the entire volume per se, if adjoining normal looking ovary is also seen. So it's not excluding, mentioning both them is the way to go ahead. Okay. How long a complex tube ovarian mass, that's a chronic unruptured ectopic, correlates with, I think beta HCG levels absolutely are of a ridiculous nonsense importance in case of chronic ectopic. They may not carry any significance per se. The clinical history is saying that there was some irregular menses with missed menses on occasions, and now the patient got a spotting. After that, there is a right tube ovarian mass which is tender and absolutely no pregnancy sign. In those patients, I would like to say that it's a tube ovarian mass, and because the beta HCG levels or urinary pregnancy is negative, there can be a diagnosis of the chronic ectopic on histopathological base rather than on ultrasound base. So it's better way to label it as a tube ovarian masses rather than chronic ectopy sequelae as a tube ovarian abscess. How long a complex tube ovarian mass? I think I have done with that. Can endometriotic cyst with acute hemorrhage within a cyst with a hyperechoic retractile clot be present? I mean, you are asking too much. I mean, if there is endometriosis, along with the endometriosis, there can be clot areas, no doubt about that. But the endometriosis is a ground glass appearance. Along with the endometriosis in that ovary, there can be features of adenomyosis within the uterine component, or there can be features of deep infiltrating endometriosis within the area behind the cervix or within the bowel. But yes, endometriotic cyst can have a clot area within the same. What I want to give a word of caution is that in a pre-existing large endometriotic cyst, always and always look for solid looking wall projections from the wall of the endometriotic cyst, because I have seen one case of endometrioid carcinoma in case of a previously known endometriosis. So always we are more worried about the solid looking projections from the wall of the endometriotic cyst, which has got intrinsic branching kind of a vascularity, and I'm not worried about the vascular areas or the clot areas. What is the beta HCG in chronic ectopic? They can be normal. They can be normal and absolutely of no significance. Can endometrius? It's done. Give some clues or diagnosis. ACCM. See, ACCM. What is ACCM? ACCM primarily is some degree of abnormal contour of the uterus. So you have a normal contour on the sagittal and axial view, where on the lateral aspect, on the cornual aspect, you have an abnormal bump. Now, this abnormal bump can have two variants of appearance. It can be completely solid, or it can be a completely a myometrial strip having hyperechoic area or a ground glass appearance within the center. It has got a lot of tenderness, and secondly, it will have a cyclical pain. So what does ACCM really means? The ACCM really means is it's a juvenile endometriotic deposits below the insertion of the interstitial portion of the fallopian tube within the myometrial substance. So it has to be somewhere closer to the cornual region on one or the either side. So always look for abnormality of contour. Again, a 3D ultrasound will definitely give you a lot of clue. As soon as you do a contouring of that, you'll find a bump along with a small anechoic area over there. So that's there. I mean, you have to look for abnormal contour. Chronic ectopic we have seen. Can beta HCDS answered live, done, again, done. This is patient Dr. Seema, this patient of mine is having, I think, personalized question. You can always email me or WhatsApp me, because it's pretty difficult to kill the time of the all other audiences. I mean, you can write to me. You can take my email address, no problem. How to diagnose edematous tube? See, uh, we have been told for years together that we cannot look for specifically the tubes. But how can the tube be seen if it has some amount of fluid within the same? Or there are features of non-fluid containing tube which shows the area of edema because of involvement of the one or the other wall. So the best way is take an axial section of the uterus, look for the interstitial tube portion of the tube, look for tubo-ovarian ligament from one or the other side. The same way which you look for the torus and you try to follow the torus, that's the area behind the cervix on both the side, looking at the uterosacral ligament, going more towards lateral aspect and looking at the ovaries. In a similar fashion, you can look for the cornual end of the uterine component. And from that component, you start looking for some normal tubes. If possible, I think I can do it next time for you to demonstrate a normal looking tube, but it's not that difficult. So edematous looking tube, which is fluid filled or non-fluid filled, or can be demonstrated with good ultrasound. Previous two sections tubectomized 2 years ago, now 5 weeks. I mean, this is again a personalized question. Better you can send me email. I can answer them very well along with the images if it is possible. When the early pregnancy at 5 weeks with UPT is positive, with few small intrauterine cystic areas with normal adnexa, can decidual reaction be seen at this stage? or it's a, see, decidual reaction and pseudodecidual sac within the endometrial component can be diagnosed and can be said and can be followed. I mean, unless you have some amount of positive finding in the form of tubal thickening, some amount of tubal abortion-like features, you still you need to follow them up rather than patient is having no pain except heavy episodes of bleeding off and off, uterine cavities, empty, follow it clinically, ask for further ultrasound in due course of time if the clinical ultrasound is absolutely normal. When early pregnancy is, I think I have answered this already. Good webinar is then. There is no term called as a bulky ovary. There is nothing. You have to mention normal ovary, normal volume, abnormal ovary, increased volume. There is nothing called bulky ovary. What we can say is that for that age group, in contrast to the normal volume other ovary, the ovary is enlarged, having normal feature. Ovary is enlarged, having abnormal feature. Which probe do you use for perineal scan? We can use both the probes. I use volume probe, which is done for pregnancy ultrasound for pelvic floor. And again, I do transvaginal ultrasound for perineal ultrasound scan also. Transvaginal probe. Excellent talk. Torsion detorsion is more known entity in case of testicular one rather than in case of the ovarian one. The only feature that probably can be there that the clinically there is a severe acute pain. Number one, the ovary is not 4 times, 5 times enlarged as compared to other. I can see that there is ovarian edema. I can see that there is arterial and venous component as well. Antral follicular ring sign is positive. There is minimal amount of fluid. Now, in such patient, I can say that it's a ovarian torsion detorsion. I think this is a ectopic pregnancy related question, pseudosac and other things. Whenever we'll have a ectopic pregnancy session, we'll do that. I mean, it's ectopic pregnancy per se is a complete talk altogether. Dr. Swapna, how to differentiate ACM from fibroid? See, ACM will have a normal myometrial rim, which is thick, appreciable, with the echogenicity of myometrial rim absolutely equal to the myometrium which is the rest of the uterus has and which is normal one. So I think we should not miss it for fibroid. How to differentiate ACM with interstitial pregnancy? Yes, no. See, interstitial pregnancy is a pregnancy. It's more towards endometrial cavity. There is no abnormal contour of the uterus. And you get what is called the interstitial tube sign positive, which is not there in cases of ACM. Again, interstitial pregnancy signs is a ectopic pregnancy talk. I think you can request to Mindray to have a ectopic pregnancy talk in due course of time. When early pregnancy, we at 5 weeks with UPT positive with few small intrauterine cystic. Again, I think this is related to intra-pregnancy, not related to this topic. If we can see whirlpool sign, still can we differentiate torsion, sir? If we cannot, yes, that's what I'm trying to say. See, whirlpool sign is primarily a cyst torsion or a tubo-ovarian torsion classical specific entity. Still, the dictum would be, see, easiest way to go about it. Normal looking both ovary, no symmetrical enlargement, negative predictive value is high. I'm not worried about. If one ovary is enlarged 3 to 5 times more, ovarian stroma is enlarged, peripherally displaced, antral follicular ring sign is positive, lot of tenderness. There is a pelvic fluid which is within the same. Young patient, acute pain, no clinical symptoms in terms of pelvic leukocytosis, acute pain, which is describing it to septic etiology. If whirlpool sign is absent, still I would like to label it to be torsion. No doubt about that. When peripheral vascularity is seen of 6 centimeter, can this rule out torsion, sir? Yes, it rules out. In case of a cyst which is larger in nature, having cyst wall showing vascularity, definitely we can say that there is no torsion. When peripheral, yes, I have done answer that. Please show some images of I think ACCUM and normal and abnormal tube appearances of USG on next. Sure, sure. I will try and do that. So thank you very much. I hope I have taken most of the questions. Dr. Mahesh,
Yes, sir.
anything else you want? I mean, any answers probably what I have given. You want to add on to that, or is that okay with us?
No, that's okay, sir. Most of the questions which you have skipped is a clinical questions pertaining to the gynecology rather, where you need a serial scan, so you need a serial beta HCG.
Yeah, that's true. I mean, beta HCG is a very good test, but in indicated patients. I mean,
Yeah.
beta HCG can be a fooling agent on so many occasions. I mean, it's very deceiving test, I always say. And secondly, for ectopic pregnancy, I think it will be unfair to deal with that in a such short period of time. Viraj, that's time to say goodbye. I
Yes,
mean,
sir. Of course, sir. It's absolutely a great session with so many amazing images and your insights in terms of diagnostic perspective and Mahesh sir's clinical correlation. I think it's a perfect blend, completing the evaluation of the transvaginal, what was our topic. So thank you so much, sir. We have Mr. Ashwani Rana, our director. He is also, he has joined. So I think we can have some words from him, sir. Sir, can you unmute? Yeah.
Uh, can you hear me?
Yes,
yes,
yes.
yes, Ashwini, we can.
Dr. Aniruddha, I don't know how to say thank you for this amazing session. And
You have to just say thank you. That's all.
all right. And also to Dr. Mahesh, personally, I haven't met him, but I'll make sure, in due course of time, we catch up. It's so amazing, as you rightly said in the beginning, that there is so much of talk about whether we talk of, ultrasound in fetus or MSK. But I think your talks have made sure that gynec ultrasound is also, becoming very, very interesting. And to see close to 200 people online in today's world, I think it speaks volumes. Really amazing. And I think, from the Mindray side, we will continue to push the boundaries and make sure what people want to listen, we'll try to, do whatever best we can do from the academic cooperation side. And it's really amazing. I'll take that liberty to, take best images from Arizona I9, which you demonstrate over here. I'm sure there are a good number of users of I9 in this group. And this is really where the best teacher brings out the best of the product. So thank you so much for everything. And we will continue to, do these kind of sessions with you. Thank you so much. And thank you to the audience, all the customers who take time to be part of this evening with us. Thank you so much.
Viraj, there are so many people
Yes,
who ask.
yes,
There are so many people who ask the questions which we are not in the preview of today's talk. I have
yes,
stated that you can share my email to them. They
yes,
can
absolutely, sir.
they can send the questions to me. I will try to honor them with best of my capabilities. And you can share my email with them. No problem.
Sure, sir. Sure, sir. Thank you so much, sir, once again. And thank you, Dr. Mahesh, sir, once again.
Thank you.
Thank you all the delegates for joining our next section. As I mentioned, we will be sharing the links and all the details very soon. Thank you so much.
Thank you.
Thank you. Good night.
Thank you, everyone.